TopMedTalk.
Hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk. Welcome back to ANZCA ASM 2023. That's the Australia New Zealand College of Anaesthetists and Faculty of Pain Medicine here in Sydney, Australia. So really pleased we've got this wonderful booth here. We've been interviewing people supported by ANZCA, the college I mentioned, and with an unrestricted grant from 3M. So thank you for these opportunities. Got two new guests to introduce, and I'm going to introduce them sequentially, starting with Professor Michael Vagg, if I'm pronouncing it correctly.
Yep,
Michael, Michael or Mike, what do you go by?
Mick is fine.
Mick is fine. Well, Mick. So I'm actually, although I'm called Monty, I'm a Michael in the background. I've been called all different things in the past. So Mick, tell us a bit more about yourself.
Sure. So I'm the immediate past dean of the Faculty of Pain Medicine for ANZCA, and I'm mostly in private practice as a pain medicine specialist in Geelong, which is sort of far south Victoria. I've got a number of roles within the college, including the chair of the Procedures in Pain Medicine Committee, and I'm also the Director of Professional Affairs, supporting the board of the faculty as well.
And pain medicine in Australia, I think, recognised at a collegiate level. It's been one of the first colleges in the world to go down that route, as I understand.
It was, yeah. The faculty was initiated in 1998, and we're celebrating our 25th anniversary this year. And we believe Australia in 2005 was the first jurisdiction where it was recognised as a principal specialty on its own. New Zealand in 2012 was the second, and Hong Kong in, I think, 2020 might have joined us as well.
And I was at the ceremony yesterday evening. There were some more fellows who were starting to join the college and recognised as pain medicine specialists, quite outnumbered by team anaesthesia, but there still seem to be a good number of them. Is it a popular specialty?
It's growing. It's what Bart Morley from the European Pain Federation calls a supra-specialty here, because we're a multidisciplinary faculty. So, my own background prior to doing pain medicine is in rehabilitation medicine. We have radiation oncologists, obstetrician gynecologists, psychiatrists, surgeons, people with all sorts of other backgrounds who are pain medicine specialists as well. So it's unique in that respect among all the faculties.
For those people who don't know pain medicine very well, can you tell us a little bit more about your working week, which I know would be typical of everyone's working week, but is it clinic-based? Is it hospital-based? Is it ward-based?
Most pain management units in Australia are part of big hospitals. There are some that are community-based clinics. Ours is kind of a hybrid. Ours is a private clinic based within a medium-sized private hospital. So we support our acute pain nurses on their acute pain rounds. We do a lot of clinic-based consulting for subacute and chronic pain. We do procedures, neuromodulation trials and implants, and we assist our palliative care colleagues with cancer pain. If people need an intrathecal port system or an intrathecal pump system, we get involved in that as well. So it's a very varied working week, and we rely heavily on our communication skills and consulting skills to get results, and we work with our multidisciplinary rehab teams as well.
And chronic pain as a subsection of pain management, is it split up that way?
So yeah, we sort of look at the three main areas that the faculty gets involved with: is acute, subacute or chronic pain, and cancer pain. And so we train in all those areas, and most of our pain specialists have a predominant interest in one of those three areas.
So thanks very much, Mick. I'm just going to introduce our second guest here, and that's Professor Malcolm Hogg. Malcolm, what do you go by?
Malcolm.
Malcolm. Thanks very much, Malcolm, for coming. Same thing, if you don't mind. Tell us a little bit about yourself.
So I started out as an anaesthetist, but saw that there was a major need and had an interest in that, I suppose, the journey, the pre-operative, intraoperative and then post-operative course. There was major requirement to improve that journey, and there's been a lot of work has since been done, primarily driven by some of the economics, but some of the medical benefits of having a planned pathway and improving perioperative care, leading to better longer-term outcomes. Subsequent to that, did some training both overseas and interstate regarding the pain fellowship, and was one of the early groups that went through with Michael to look at becoming a specialist. And then from that position, it's been about leadership, leadership in teaching other anaesthetists, nurses, allied health team members to develop stronger pathways for better pain management. Now, whilst the faculty's done a great job in producing fellows of the faculty with specialist training, they still work with a lot of non-faculty pain medicine physicians, and that's going to continue. So a lot of our work perioperatively now involves geriatricians who don't have a pain medicine background, or general medical physicians who are doing a lot of the post-operative work. In the past, this was often left to anaesthetic departments and some anaesthetists if they could squeeze in a post-operative round, which often they can't. So I think the clinical care models are developing to be more specific and more skilled.
Malcolm, can you tell me what you've been lecturing about at this or listening to at this particular meeting? What's hot at the moment?
There are a number of hot topics. I think that whole pathway and developing streams and approaches, having a set menu, so to speak, might be fine for 85 to 90%, but there's still going to be people at either end of the spectrum that need specialist input, whether it be perioperative medicine or whether it be cardiac advice pre and post, whether it be haematological advice. So it's how do you deliver a service that's economically viable and maximises both your service delivery parts to get the best outcomes. So you don't get the complication rates, but also you have a streamlined approach so that you're more efficient for those that are going to do well with surgical management, basically.
So in the last few years, I get the impression that the broader population has heard a lot more about opioids and their use in the context of elective major surgery, and whether there is a suggestion that we as anaesthesia providers, and particularly they've talked about it in the United States of America, have contributed to people being opioid naive and ending up more possibly opioid dependent after major surgery. Has that been a topic here as well in Australia?
It's been a topic over the last 5 or 6 years, really, as the government in Australia, as well as the leading healthcare bodies, have addressed the problem with policy documents and regulatory changes. So I think in many ways we're in front of the curve of that topic, and now the public are realising what the implications are and why we've done those changes. Those changes have been made.
Yes.
And the potential benefits of those changes. But it's also exposed where we're missing things. So one of the problems in the States was, yes, really aggressive opioid use operatively, but then a real gap in follow-up and care in the community. And some of those system problems made the problem in the North American market worse than it was in Australia, but it's still significant in Australia. And we're moving to address some of those system problems, which means clinical pathways, different way we use opioids, earlier communication to general practitioners, earlier access to specialist follow-up, to try to address the reasons people have got into trouble and societies have got into trouble overseas.
One of the big discussion points in the United States of America seemed to be the tendency in some places to send people home with large amounts of, in particular, OxyContin was a big discussion point, and that then leaking into the community. When we had joint meetings between ourselves in the United Kingdom and our colleagues in the USA, we seemed to be looking at that through a different lens. In other words, we were quite mean with what we'd let people take home in the UK. On that spectrum, where would you say it was or is in Australia?
Well, there's a basic difference, isn't there? You've got an NHS, which is a systematic, top-to-bottom sort of healthcare design, versus in America you've got essentially a consumer-driven private sector, which doesn't necessarily fit in together with different pieces. So that's in part why there was high prescribing in acute care and then not a follow-up plan. Australia's sort of sitting in between there. We've got some regulatory bodies that have allowed some restrictions on discharge dispensing because of the PBS from funding, but also package sizes, etc., whereas they didn't have those restrictions in America. So the ability to get into trouble over in that part of the world was higher and different.
Yeah.
And possibly there's a cultural thing there too. So consumer-driven versus clinician advised healthcare. So when the clinician makes the assessment and the advice about management versus consumer driven, I need more medications and I will service the consumer in a socio-political sort of construct.
So, Mick, as part of this discussion, we started to hear about the idea that we should acutely possibly strive to have opioid-free anaesthesia. In other words, now the opioid, which is sort of fundamental component of the upper end of pain-relieving properties, was now an evil thing that we should avoid at all possible costs.
Yeah. And I think that obviously mischaracterises what opioids are good for. I mean, they still are probably the most effective anti-nociceptive class of drugs that we have. But again, if you can do just as well without them, then you don't have the problem about getting people off them afterwards. What's been really interesting locally here that we've been perhaps a little ahead of some other jurisdictions is this concept of opioid stewardship.
Yes.
Where we have, it's getting built into the systems, as Malcolm was saying, the idea that you should communicate with a person's primary care doctor prior to their discharge what the expected trajectory of that person's weaning of the opioids post-operatively should be, and you provide those from the hospital so that if the primary care doctor has to keep prescribing, they should have an understanding of how long it's expected to do that for. And the other thing that has been a major change in practice in Australia is that the routine use of sustained release formulations is being strongly discouraged now in favour of, particularly in that 72-hour perioperative period, of using short-acting opioids only, so that you're more responsive to the person's pain, you have fewer incidences of ventilatory impairment due to opioids, but the patients actually get better pain relief. And the evidence on that's very counterintuitive, but the evidence is actually becoming quite compelling that by routinely using long-acting opioids, it seems as though all we're doing is exposing patients to more opioids, which they have trouble getting off afterwards.
So to that point, one of the sort of shocking messages that have been shared with us as team anaesthesia, again, a lot of it coming out of the United States of America, is that we're sort of responsible in some way for creating addicts.
Yeah, and again, I think that mischaracterises it because people who have the risk of addiction largely is in the brain of the person who gets addicted to things. That's what the evidence would tell us. What we're doing is we're exposing some of those people who wouldn't necessarily have been exposed to it to something that may trigger those behaviours. But in the much larger group, what we're doing is we're putting them on something without a plan to take them off.
Yes.
And we're not supporting their GPs, or their GPs may be scared to take them off it. And so we're creating situations of opioid-induced hyperalgesia or physical dependence, which is not necessarily the same thing as addiction, but the GPs and the patients don't feel confident weaning themselves off, and so they stay on them, and then they run into other secondary problems once they've been on them for a while.
So if you started the prescription in hospital, do you keep some ownership of the long-term?
Yeah.
Because you choose to keep ownership of it, or because you are supposed to keep ownership of it?
Well, you keep ownership of the plan.
Yeah.
So you share the plan with the patient, with the patient's family, with the primary care. And so if someone has been on a normal trajectory in hospital where they have rapid relief and they have good anti-nociception, communicate to the GP that this person should be off opioids within a week after they go home. If they've been a more complex course, a complex trauma, maybe they've even had sustained release opioids commence 3 or 4 days into the admission when their requirement for such things is established, you might communicate with the GP and say this person should have these weaned off over 3 to 4 weeks. But it's that personalising of the risk and personalising of the plan for the discharge that is the key to getting people off them safely.
And Malcolm, what about the chronic? I mean, in London, certainly in my practice, we saw quite a lot of chronically opioid dependent or patients who needed opioids, who were on very, very high doses, who were coming in. Any programs to try and wean them off preoperatively? Does that work? Or
when I reflect back on this, I look at why are they still on it? So why have the opioids at a high dose and still having significant pain? So in some ways the opioids have failed, and like Mick has said, they've become dependent and there's a loss of benefit of the opioids, and it's likely sensitised the pain system behind it. The second sort of reason is that the disease has changed. So it's gone from being a nociceptive, structural, opioid responsive problem to being a more sensitised or a different, even neuropathic type pain, which is less responsive, if responsive at all, to opioids. And so the strategy should have been changed to better reflect the disease mechanisms. And then the third reason is psychosocial. So stressors, anxiety, addiction risks that were there that maybe not have been recognised have then elevated it so that they have become dependent and in a small number overtly addicted. But there might be other social factors to that. So that's sort of the background, and then you say, well, how can we get them off? And in the actual trials performed, mostly out of the North American areas, the outcomes have been very disappointing.
Yes.
So even multidisciplinary input, lots of psychoeducation, goal setting, gradual dose reduction, your response rate is 30 or 40% probably at best in getting the doses down. And often those studies have not actually said my goal is to get them off opioids. It's actually the goal is to get the opioids down and or onto a safer opioid, specifically buprenorphine in the North American market. They're utilising that because it has less respiratory depression. So I think it's difficult. Once they're up there on those doses, it takes a lot of effort and a long time and a very motivated patient to actually adequately get off or into a much safer dose range. Should we have a strategy? Should we have a supported approach for more aggressive dose reduction or rotation, like ketamine infusions, etc.? There's been no randomised controlled trials of more aggressive treatment. It's been mostly case series and a few small trials showing how difficult it is. But because it's such a large problem, I think it is time that the healthcare sector and the researchers said, right, how do we get this improved, both at a biological but also a social and physical, functional level, so we get better outcomes for our patients.
And when one pre-opsies patients as a non-specialist, it's not unusual to find that it's very, very complex history. There are social reasons, sometimes there's deprivation, there's multiple addictive behaviours. It's a big challenge.
Yep. And given the lack of evidence and the benefit of how we're getting people off, in that we can't get them off well, we should, as a secondary component, improve them if they're remaining on it. So improve their health. So by doing some opioid governance, so to speak, in the community. So checking their dental health, checking their respiratory status, their hormonal status, reinforcing the benefits of dose reduction at every opportunity. If they are coming in for surgery, it is an opportunity to give them a ketamine or an opioid-reduced anaesthetic technique, which may reduce the component of their tolerance and dependency and lead to a better outcome. So some of our patients who come in on high-dose opiates for surgery, you think, well, they're going to go back on higher doses. We can use dexmedetomidine intraoperatively, ketamine postoperatively, lots of clonidine, lots of education, and get them home on lower doses if we've done a good job, and communicate to the GP with a plan. And so you're using that opportunity as a one step in a bigger journey of better health, whether they remain on opioids or not.
And I was hearing at one stage that ketamine presented an opportunity for some sort of reprogramming. Is that playing out?
Correct, but it washes out. So the benefit of ketamine washes out by 6 months in all, and there's been no good randomised controlled trial. But in the several prospective series, yes, you can get dose reduction on ketamine, but at 6 months, most people's opioids are back to where they started from. So the driving force for why the opioids were used at high doses in the first place remain. So you still need to address them, whether that be anxiety, whether it be neuropathic or sensitisation pain strategy. So yes, ketamine, yes, but then put it in a package to consolidate any gains you've made by getting the doses down. You may, if struggling, you may then do a second ketamine or even a third ketamine. In the perioperative period, we found dexmedetomidine in basically super therapeutic doses of clonidine, causing some hypotension, causing sedation, under anaesthesia and or into recovery period ICU, really can be quite more aggressive at a biological level in reducing opioid tolerance and allow you to drop the doses without necessarily getting into overt withdrawal.
And is this experiential that you're explaining to us, or is that large trials?
There's some studies of this,
Okay.
but it's not. It hasn't been done specifically as that as a goal. It's been done there to allow opioid-reduced anaesthesia.
Yes.
So if you go back to why we used opioids for surgery,
Yes.
haemodynamic response. So imagine the first cardiac operation, you're doing a sternotomy in someone with a dodgy heart, and they couldn't get through the sternotomy.
Yes.
So high dose, super therapeutic doses of opioids blunted the haemodynamic response. So if we remove the opioids or reduce them significantly intraoperatively, we need to manage the haemodynamic response, and dexmedetomidine and lignocaine and possibly ketamine come into that. So by going opioid reduced in our anaesthetic, we need to increase the non-opioid strategies.
Does this resonate, Mick? Same
No, absolutely,
recipe?
yeah. And I think I'd reinforce what Malcolm's saying about the difficulties of getting people off. The time as a perioperative anaesthetist, when you're assessing them, you can note those high doses of opioids. You can say, yes, we will do as much as we can to not make this worse. But, poorly planned or informed crash reductions in opioids lead to rebound onto larger doses.
Yes.
And they cause increased distress. And just the same as you can provoke an Addisonian crisis by taking someone off their prednisolone perioperatively, do the same thing with their endorphins by taking them off their opioids too abruptly. So the idea is to maximise your use of other modes of analgesia and encourage them towards a long-term dose reduction, but don't try and do it all on that admission. Yeah.
So I mentioned in passing OxyContin, and I think I've got that right in distinguishing OxyContin from oxycodone, for example, or other derivatives. There's been so much in the popular press, in the media, etc., about that drug. Is it used in Australia?
The rates of prescribing are going down of
Yep.
oxycodone. Oxycodone immediate release is probably the most prescribed in hospital analgesic. That causes a lot of issues with rapid tolerance development, and the characteristics of oxycodone that make it so good as an acute analgesic are the very ones that cause huge problems with long-term use. So you get relatively rapid dose escalation, relatively rapid hyperalgesia developing compared to a lot of other opioids. So rates are going down, but we don't know what the right rate is.
Okay. So it's still there. It's still a useful tool. It's how you manage
Again,
it.
it is exactly right. As long as you understand the limitations of the drugs that you're using, and use them for what they're good for, and aggressively manage the risks that you're exposing patients to, then and patients can understand if you explain to them that oxycodone, particularly short-acting oxycodone, it's a great friend in the short term, but it's a friend that will wear out its welcome in the medium to long term.
So we're coming close to the end here. Anything very new that we've heard at this meeting that the broader audience should know about, or heard about in the last year or so, that the non-specialists should be thinking about?
As a rehabilitation physician, I'm excited by the amount of multidisciplinary conversation going on.
Okay, great.
So we heard it in the acute pain session, heard it in some of the perioperative sessions as well, and so I think that's very welcome, because in rehab we've been using the skills and expertise of our allied health peers for a long time.
Yes.
And I think the evidence is beginning to mount that it's actually a good idea as well in the more acute parts of the hospital. So that's been a pleasant surprise for me here.
Malcolm?
Yeah, I think in a similar vein as how you integrate optimal pain medicine. It's not just the specialists that should be doing this. This should be across the board. So the principles are applied to patients going through acute care, and their transition into a recovery phase. And that means us educating our colleagues, but also them then acting as part of the proper protocols to optimise longer term outcomes. So then you're screening people who are demonstrating they're at risk, and you're getting them into specialist care earlier. Same thing, I gave a presentation on COVID, and reading through what's happened there, it's been almost, we've treated the acute COVID, and then it's only now we're saying, how do we better improve people's recovery from COVID? We sort of missed the opportunity there, rather than saying, all right, early on, yes, we're getting these people better, now let's focus on the subacute phase, let's focus on the chronic phase. We're sort of almost playing catch up, and those principles should be applied to perioperative medicine, and probably should start preoperatively.
Preoperative. So prehabilitation is...
Well, to some degree.
Yes.
And the evidence of prehabilitation is not very strong, but the principles are strong.
Yes.
And expectation setting is one thing, but I would think better glycemic control for those who are diabetic, improves infection rates, etc. Optimising, respiratory function, cardiovascular function preoperatively, all would appear. So get a plan in place for people to optimise their health if they're going to have planned major surgery.
Any new challenges coming over the horizon that you're starting to see? You mentioned, for example, long COVID mixed in there, but anything else? Some countries have seen a greater, use of legalised cannabinoids and...
Yeah, I think there's an interesting old paper now that looking at what patients want to know in cancer care, and 75% wanted to know about cannabis, but of their doctors, only 15% were willing to talk about it.
Right. So
it's an area which is driven by patients. I also see this being done with other supplements. So there's a great interest. There's homeopaths, there's osteopaths, there's chiropractors doing treatments in the community that a lot of the surgical and perioperative physicians don't know enough about. Yes. So I think we at least need to recognise that and understand that. And this part of my interest in COVID was that we haven't taken enough interest in the person who's got long COVID, because those patients are then going to be presenting for surgery soon. And we should know how to assess them and how to understand them and how to talk with them to get a better outcome. Do you take people off cannabinoids if they're accessing it? Do you take them off their supplements that might be interfering with their coagulation profile, etc.? So we should inform ourselves about this, and so we can give the appropriate advice.
Mick, anything else that you're seeing coming over the horizon?
No, I think one of the things that we're seeing a lot of is survivors of complex care. When I started in pain medicine 20 odd years ago, these people didn't exist. People who'd had, multiple rounds of chemotherapy, multiple surgeries to do radical excisions and pneumonectomies and other stuff. The people are surviving these things where they didn't used to, and they're surviving and actually trying to go back to normal life afterwards as a survivor, and many of those have poorly recognised chronic pain. And that's a particularly challenging new group that wasn't around when I started my training. Yeah.
Well, thank you both very much indeed. Enjoy the rest of your meeting. I just want to say thank you to everyone for listening. Thank you again to ANZCA and to 3M for their sponsorship, and also to our other major sponsors, GE Healthcare, Edwards Life Sciences and Medtronic. Without your support, we couldn't keep this as free, open access medical education. I'll be back shortly to talk about environmental sustainability, so we look forward to that.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.